side by side so that we understand them better. Now, sebaceous adenomas morphologically present as single yellow, smooth or sometimes scaly or crusted papule, generally over the head and neck area. Sebaceomas are generally present over the face and scalp. The morphology is similar to that of sebaceous adenoma. They are in the form of solitary yellow papule. Sebaceous adenomas, they generally appear in 5th decade or later, while sebaceomas appear even later, 7th decade and after. Now, most important point how we identify is on histopathology. In sebaceous adenoma, you will have well circumscribed mature sebaceous lobules. The peripheral row of small basaloid cells will rest. So, the most important differentiation will be on the basis of histopathology. Now, in sebaceous adenoma, they will be well circumscribed mature sebaceous lobules, peripheral row of small basaloid cells with rest of the cells being mature sebocytes. Now, how do we identify sebocytes? Sebocytes have multiple cytoplasmic vacuoles which will be indenting the nucleus. So, here the major component is of sebocytes and the basaloid cells are only present in the periphery. While in case of a sebaceoma, you will have predominant basaloid cells with a small number of mature sebocytes. Sebaceous adenoma will have connection with epidermis, while this connection is missing in case of sebaceoma. So, this is how we differentiate. Now, there is another terminology, that is sebaceous hyperplasia. In sebaceous hyperplasia, these lobules are arranged around a central hair follicle infundibulum. So, it's easier to differentiate whether we are dealing with just sebaceous hyperplasia or sebaceous adenoma or sebaceoma. So, this is how they look like. In sebaceous adenoma, you will have these peripheral palisading basaloid cells, while in the center mainly will be sebocytes. While in sebaceoma, the majority of cells are going to be these darkly blue staining basaloid cells with intermittent sebocytes. Now we move on to tumors having sebaceous differentiation. Now, sebaceous adenoma and sebaceoma, sometimes we are very confused as to what we are dealing with. Now, these are two different entities. Both are benign tumors composed of incompletely differentiated sebaceous cells. We are going to see them side by side to understand better. Sebaceous adenomas clinically present as single, yellow, small, smooth, sometimes scaly or crusted papule, generally over the head and neck region. Sebaceomas, they also present as solitary yellow papule, but generally over the head and neck area. The age of onset for sebaceous adenoma is 5th decade or later, while sebaceomas, they occur even later, 7th decade and thereafter. Now, the most important differentiation is on the basis of histopathology. In sebaceous adenoma, we have well circumscribed mature sebaceous lobules. Now, these sebaceous lobules have peripheral row of small basaloid cells with rest of the cells being sebocytes. How do we identify sebocytes? They will have multiple cytoplasmic vacuoles that will be indenting the nucleus. Now, what happens in a sebaceoma is that majority of the cells are basaloid cells with only a small number being the sebocytes. Another important differentiating point is sebaceous adenoma will always be attached to the epidermis, while in sebaceoma, there is no connection to the overlying epidermis. So, this is an important differentiating feature. Another thing that we come across quite commonly is sebaceous hyperplasia. Now, what happens in sebaceous hyperplasia is that we have lobules, the sebaceous lobules, they will be arranged around a hair follicle infundibulum. So, it is easier to tell each one of them apart on the basis of histopathology as compared to when we see them clinically. Now, on the left side, we have sebaceous adenoma. What you see is that predominant cells are the sebocytes. That is why the tumor looks a little lighter in color. While on the right side, we have sebaceoma, where the predominant cell type is this dark blue cells, the basaloid cells, and few of them are only sebaceous cells. Now, another thing that we come across is sebaceous carcinoma. Now, it's a malignant tumor composed of cells showing differentiation towards sebaceous epithelium. Women are more commonly affected than men. This malignant tumor, like all other malignant tumors, we encounter generally in old age. The distribution is over the upper eyelid and the head and neck region. Generally, a single firm yellow-orange lesion is appreciable. Most commonly, we see them over upper eyelid and head and neck region. Morphologically, they appear as single firm yellow-orange lesion having a translucent appearance. Histopathologically, we will have multiple irregular lobules composed of cells in various stages of differentiation. Mature sebocytes to undifferentiated baseloid cells will be seen, and if you will look at histopathology, these cells will not be as smooth, as symmetrical as we saw in sebaceous adenoma or sebaceoma. We will have many mitosis, we will have many atypical cells which will be a little larger, having irregular nuclei, and that will give us a clue that we are dealing with a malignant counterpart. Now, in the same breath, I would like to discuss about nevus sebaceous of Jadassohn also. Although it's not a true appendageal tumor, but sometimes differentiation is difficult. It's an organoid nevus which is composed of mature sebaceous glands. These are seen in 0.3% of neonates with an equal incidence in men and women. The lesions are congenital, so you will see them generally at birth, but with age they change their morphology. Sometimes the patient will come to you with onset not at birth but a little later. That is also possible. They'll generally be over the scalp or face. They present as slightly raised yellow to tan plaques having a smooth or velvety surface. If they are on the scalp, they will be devoid of hair. And with age, or as the child attains puberty, they become papillomatous. The surface becomes papillomatous. Instead of being smooth, it becomes irregular. Now, dermoscopy helps here to identify it. There are multiple grouped small white-yellow globules within the lesion. Now, a nevus sebaceous can occasionally transform into a basal cell carcinoma. In the past, it was believed that this happens quite often, as often as in 4% of the cases. But now it has been identified that many of those tumors which arose in nevus sebaceous were actually trichoblastomas and not basal cell carcinomas. So the incidence is pretty low. As a result, there is a move away now from excising all of these nevus sebaceous, and instead we can offer a watchful approach. Large lesions are occasionally associated with Epidermal Nevus Syndrome. So if we have a patient with a very large nevus sebaceous of Jadassohn, we should try and find out its association with other features of Epidermal Nevus Syndrome also.